Hello everyone, my name is Dayna Pool and it's my absolute pleasure today to present this webinar. And what I'm presenting today is something I'm super passionate about, and it's kind of really molded the kind of work that I do, the research that I do, and the kind of clinical practice that I'm involved with. So the title of my presentation is Developing a Roadmap for Clinicians in Choosing Interventions for Enhancing Muscle Impairments and Function in Children with Cerebral Palsy across all functional levels. I know a lot to cover in just 15 minutes or so, but I'm going to hopefully lay down some of the thoughts that I've been really developing over the last 10 years. So we all know the ICF. It's lovely. And I know when I first graduated, I was really grateful to have a framework where I could actually conceptualize my thoughts, think about what are the assessments I need to do, and what are the kind of interventions I can do across all of the levels. You know, we've got body structure and function, we've got activity and participation. We can think about the environmental and personal factors. And the more and more I worked with people with cerebral palsy, I began to think really deeply about what was next for them as they got older. And when Mark Peterson first published this article that really just transformed my thinking, it was about 10 years ago now. And I think we all have these moments where you have an article that really just rings true into your practice at that particular time, and it just got me thinking. So this is really a cycle that describes what can happen if we have diminished activity. An individual who has diminished activity, it can lead to premature sarcopenia and progression of motor dysfunction. It can lead to less participation opportunities. And from there, it sets off this host of physiological effects like adipose tissue deposition, reduced aerobic fitness, and muscle weakness and fatigue. And what was really alarming, what I was reading at the time, was that adolescents with cerebral palsy was sedentary for up to 96% of the day. And I was even more alarmed when I read that over 70% of adolescents do experience some sort of functional decline in mobility as they get older. And so whilst I looked at this and I thought, well, the overall risk of cardiometabolic disease as they get older increases, well, what can I do now as a clinician and as a researcher? And in this cycle, I could see where I could possibly intervene. So this is where I started. I'm like, well, there's an intervention opportunity here. I can increase activity. And then as I was searching through the literature a few years earlier, Adam Shortland presented, this graph, which I think a lot of people know. On the y-axis, you have muscle mass, and on the x-axis is age. That solid line is what typically happens. So as we get a little bit older, we increase in our muscle mass and we cross this functional threshold that allows us to do a lot of things that we want to do during the day. And as time goes on, our muscle mass reduces and we can start to dip below that functional threshold. And we tend to see falls and decreased mobility as we get older. But for individuals with cerebral palsy, that peak is far less than what you would expect for someone who doesn't have cerebral palsy. And then I thought, well, that's not great, because what now happens is that crossover below that functional threshold also happens earlier. So I thought, okay, our goals right here are to build muscle mass and maintain muscle mass. Like, that is the role that I feel like I need to have and play in my clinical practice. And then really recently, I was looking at more research by, Sian Williams and her team, really looking at this curve as well. And recently they published this article, same sort of thing, the solid line representing what typically happens, but really mapping out now what happens across the GMFCS levels. And here we see GMFCS level 1, still not peaking as high and crossing that functional threshold a lot earlier. And as GMFCS levels increase across 2 and 3, we can see that peak gets less and less. And that crossover to the functional threshold happens earlier. And we start to understand that functional decline. So once again, I'm compelled to look at the fact that we need to build muscle mass and maintain muscle mass. What I was really struck by was how early does this happen? Like, when does our muscle mass actually look different to what happens typically? And there was this article that was published in 2018 that were looking at the size of medial gastrocs. And they measured the volume of the medial gastrocnemius in typical development in the red dots, and then in children with cerebral palsy in the hollow dots and the solid black dots. And you can see right there, around that 9-10 month area, there's that separation that starts to occur. So we can see that the growth rate in children who are typically developing is nearly twice as much as children with cerebral palsy. Now, there's a lot of factors related to that. There's, the neural activation and how much input there is, but there's also activity, right? So Oliver Fisher and his colleagues published their 24-hour activity guidelines for children with cerebral palsy back in 2020. And it was really trying to lay out, where can we actually look at physical activity and sleep and sedentary behavior, and what can we aim for that's really feasible and possible for long-term health. And in here, he was saying, all right, let's aim for 60 minutes of daily physical activity. Let's try to sleep between 10 to 13 hours a night. And let's not sit for any more than 2 hours at a time. So I like this model. It gives us a good way to conceptualize and think about what 24 hours looks like for our children. So then the question for me became, well, what happens during the 60 minutes? What can we do? So for this, I turn to the green light interventions. We know that Anna Novak and her team, as well as Michelle Jackman, Kathy Morgan, they have now published so many articles and systematic reviews where we can see these common trends and ingredients of green light interventions. And in a nutshell, it means we have a hands-off approach where the child is initiating the movement. And this is important that we're working on meaningful goals, incorporating social interaction, having an enriched environment, working in an interdisciplinary framework, and having active participation. Now, all of this is generated to try to improve motor skills, so mobility. The question here then becomes, well, why do we need to implement this? And then importantly, how do we implement this? Just last year, Heather Feldner and her colleagues published this on-time mobility framework. And I absolutely love this framework. It talks a lot about this paradigm shift in a way for therapists and clinicians and researchers to think about how we can encourage activity right from an early stage, but considers a few parameters. So in brief, she talks about timing as a core early intervention principle. Are we looking at early enough? Now, when you consider the muscle development, that separation that happens as young as 9 months, just in muscle volume, we need to be thinking about early, within the first 12 months of life. And there is a matter of urgency. It's the definition of what a human rights accountability is, because mobility is a human right. Being moved passively isn't helpful for social, cognitive development. So there's an urgency about getting children moving and early. And this can happen in a few different ways. It's multimodal. It can be with body weight support, powered support, supported stepping devices. But importantly, we're thinking of different ways with adequate frequency. So multiple hours a day of self-initiated mobility is what we should be aiming for. As a reminder, toddlers take 14,000 steps and fall 100 times in 6 hours. That's a lot of movement. And this just highlights the, quote, importance of self-directed variable movement in natural settings with sufficient frequency. And what we need to do there is, importantly, making sure we put it within context, because I quote again, development of social communication emerges from mobility that's nested within social environment. So I feel like that's really compelling with regards to what we need to do and how we need to do it and why we need to do it. So Ginny Pallig and Rosalind Livingstone have recently published a whole host of articles that really are encouraging children to move as early as possible. And the we learn to move and move to learn each day really comes through. And in this diagram that they recently published, you can see here that at 12 months, you're really encouraging for supported stepping to be thought about. Now, I would have to say traditionally in a lot of therapies, and certainly how I was trained very early on, about 20 years ago now, the thought was really to try to, reflex integration. It was about more passive movements and static strengthening. It was less about functional activities. So this was a big shift to kind of go, well, we're less looking at movement patterns and more looking at function. And it fits in with all the F words. Right, so for children who are GMS level 4 and 5, these are the F words that really support the need for supported stepping. We've got these fitness benefits that are lifelong, function, friends, the interaction that happens within those first 12 months is very significant. The interaction of family, fun, of course, and the future. We want to be setting up healthy habits right from the beginning. And so we also need to start, as with the mobility framework, on time as much as possible. And it is entirely possible. So here at the Healthy Strides Foundation, that's what we've been founded on. It's the idea of getting children up and moving when it is most necessary to do so. So around that 12 months to really get them weight bearing, experiencing movement with friends, with family, and interacting. But let me just take it back just one step here and talk about the GMFCS levels. So GMSS level 1 and 2, we know these children are functionally ambulant, but they do have some restrictions on uneven surfaces. And we can see that on that curve there, even children of GMSS level 1 and 2, they don't peak nearly as high, and they cross that functional decline, that threshold stage, a lot earlier. So coming back to this cycle that Mark Peterson had published, and you look at all those components that can really interact to lead to increased cardiometabolic risk. Well, there's an intervention opportunity right there, muscle strengthening. There's an intervention opportunity, again, to increase participation opportunities, and there's a lot of literature on that. And there's another opportunity to increase activity, all of which we can aim to increase the opportunities for independence, enjoyment, and participation. How do we do this? Well, Noel Moreau, Richard Lieber recently published an article about strengthening muscles, getting down to basics. Dan Damiano had published about 15 years ago saying strengthening is just such an important component of our treatments. And if we do it right, we can increase muscle strength and muscle volume. And this table is just excellent when we look at the parameters of how we can strengthen, thinking about the ranges, the frequency and the dosage, the duration and the rest periods. You don't need a gym setup to be able to do a lot of these things. You can incorporate it in so many different ways, but we need to be thinking about the frequency and the kinds of sets that we can incorporate into our practice. But what about incorporating strengthening and use or just activity within a functional task? Well, we have functional electrical stimulation, an area that I've looked into quite deeply before, where you can stimulate the dorsiflexors during the swing phase of gait. There's a lot of devices now, but back when I did my PhD, it was the walk aid, as you can see here. And we found that children in the intervention group that used the FES device daily for about 6 hours a day for 8 weeks had a significant improvement in their muscle strength and volume post-treatment. And you can see that right there. That blue line indicates a real significant improvement in their muscle volume. And that symmetry ratio between the affected and unaffected side became closer to 1. But it was use dependent. When you took it off, that difference became lessened. But it just shows that activity can be so important, especially when looking at muscles that have poor selective motor control and you can't quite activate it during functional tasks. Okay, well, what about children of GMSS levels 3, 4, and 5, whom we know have increased sedentary behavior, whom we know have this deteriorating muscle morphology? Well, one of the interventions that we've looked in quite a fair bit here is locomotor training, a way to get children upright, but also considering their challenges, which is why it is partial body weight supported treadmill training that's combined with overground walking. And the reason we do it is because it's really specific. You train like you walk. You get adequate repetition. And that's really important from a frequency perspective. And the most important part here is active participation. Now, we've had a lot of outcome measures of which we've published before, but because we know that muscle strength and walking speed are so closely related, we did measure 10-meter walk tests. And here you can see a significant improvement in the time it takes to walk 10 meters. This is after a 6-week intervention for children GMSS levels 3, 4, and 5. And following those parameters again have been published about, fitness and strengthening. But can this start earlier? Well, I think it can. Here we have a really young child. He's 12 months old. He's been spending his first 12 months really on the floor, but really keen to be upright. And the parents can only be there so many times a day. So here you can see that he's actually taking some steps and initiating some steps himself within the clinical setting. And that again just sets him up so that in the home setting where the mum has sourced a walking frame, he can now be upright for longer periods of time. And now we're looking at his social development. We're looking at his emotional development and his cognition and his vision. And we're looking at how he can explore his environment. The key here is that he is upright. And yes, he's got wonderful curls. Now, this was an 8-year-old boy, GMSS level 5. And I've shown this video before, and it's always compelling. You can see that he's trying to do the 10-meter walk test here. It's very difficult. He can do it, but it's very hard. And you can imagine over time, this will be hard to maintain. It'll be hard for him to want to continue to do this. And this 10-meter walk test took 2.5 minutes. And after the 6-week intervention of locomotor training, he completes his 10-meter walk test in just 20 seconds. And this is consistently what we've been seeing. So we can see that we can use supported stepping devices, but of course, we've got a lot of different mobilities formats. We've got race running and we've got adapted cycling. But we also try to develop another intervention, just being creative in our program called CP Move Time for children who are GMS functioning within GMSS level 5 and really don't have a lot of active movement. Again, providing body weight support and following the parameters of muscle strengthening. So 5 to 8 repetitions of good pushing and standing and that eccentric control back down again. And so we did this for 3 times a week for 6 weeks, just trying to find another way of getting children who can't be in supported stepping devices to be upright and experience and push and be able to work on a lot of those strengthening components. And in this single subject design, I've just got one subject here to share with you today. She's nearly 13 years old, dyskinesia and spasticity. And in this single case design study, you can see the red vertical line that indicates when the treatment starts. And you can see in the red dots, that's the improvement that's noted there. So this is bowel functioning, significant improvement, being upright, being active, less constipated. Exercise tolerance, again, this was the goal based on using her walking frame at home. There's an improvement there for sure. And then reductions in leg stiffness. So here was the ability to be able to get change with greater ease. Again, just looking at physical activity that has a significant impact in a lot of domains that relate to mobility. So when we go back to this on-time framework, we can see that we really need to be looking at these green light interventions because the concepts and the principles here have been proven time and time again of how we can learn new motor skills and therefore be more active. We need to think about these multimodal approaches. How can we get children upright in a safe way? And thinking about that within a 24-hour sort of program, but importantly, making it fun, making it contextual all of the time. So my main message here is that we need to start early. We need to start early to build these healthy habits, and we need to use these green light intervention ingredients. It fits together really nicely, and that just shows where the research is really heading. We want children to be as active as possible, and we want them to be initiating the movements. And I hope this helps us to be more compelled to leave these red light interventions or the red light interventions that contain those ingredients, you know, the reflex integration or the therapist-initiated movements or moving surfaces. We need to be thinking more and more about the modern understandings of neuroplasticity. It is now so far different to what the understandings were of 1970. And whilst that's what we had at the time, it's evolved and changed so much, and we know what is far more effective. And the reason I go on about this is because there is a sense of urgency about this. We know that these changes happen early, and part of our job is to improve healthy lifestyles for the long term. So when we're thinking about not just mobility, but social, emotional, cognitive development, this is part of our job. And this video hopefully shows how we can do this. This is a group of children around 12 months.
Good girl.
And whilst this happens in this more clinical setting, the whole idea is to make sure we translate it into their own home environment. All these children now have their own walking devices or supported stepping devices or bikes, and they're up there and they're moving. And that is the absolute key. So I want to leave you with, we learn to move and we move to learn. And that's me for my presentation. Here are my contact details. I'm always very happy to connect, obviously through the Healthy Strides Foundation. And of course, you can always contact us through, the Research Works podcast as well, which is the studio that I'm in at the moment.